Evening. This is Dr. Scott Warden, the TOS guy from really rainy and stormy California. Today, we are really blessed to have a great panel with us, and I'm looking forward to this talk so much. And I'm going to start this right off with asking each person to introduce themselves, state their specialty, and where they're practicing. Hi, Rob. Would you like to start?
Sure. Hey, again, thanks, Scott. We're really grateful to be part of this. Rob Hagan from St. Louis, Missouri. I'm a plastic surgeon by training that practices predominantly peripheral nerve surgery. My interest in TOS, neurogenic TOS specifically, started kind of early to mid 2000s, and have just been kind of developing different strategies for helping take care of these patients ever since.
Hi, Fareed.
Good evening. Thank you very much for including me with this amazing group of surgeons. It's really an honor, and thanks for the invitation again, Scott. I am a thoracic surgeon. I'm professor of surgery at University of Central Florida in Orlando, and my interest in TOS is really the newer things. Actually, one of the concepts for tonight, from my standpoint, is to share some of these newer, sort of more controversial things with my colleagues, as well as the audience, because I'm hoping that they would get excited about some of these unusual ways of looking at this disease. Thank you for including me.
Passion is super important in TOS, we all know. All right, Art, hi.
Hey, Scott. So I'm Arthur Jenkins. I'm a neurosurgeon by training. I actually started out, I'm a fellowship trained in spine surgery. Also did some work down in Louisiana, in New Orleans, with Dr. Klein in peripheral nerve surgery early in my career, and then didn't do anything with TOS for 10, 15 years until I actually developed a minimally invasive way of taking out cervical ribs, published that. And then the next thing that happened is I started getting flooded with patients with regular, more garden variety TOS, if there is such a thing. I mean, TOS is so many entities, but that I was just started talking with my vascular colleagues, first referring them to my vascular colleagues who were the ones who did primary TOS where I work, and then started working with them, and then developed my own way of doing these minimally invasively through an infraclavicular approach, using some of my neurosurgery skills. And so I kind of got back into the whole thing after going full circle with my training. And so it's been an interesting journey. I'm looking forward to hearing what Fareed has to say, because I know that one of my biggest issues with this condition is we have no idea what's driving the damage to the scapula that leads to the misuse, the abuse of the neurovascular bundle by the innocent bystander of the first rib and the clavicle and other structures in the area. So I'm constantly trying to learn more about this, and I hope you guys can educate me on what I don't, some of the many things I don't know.
Thanks, Art. You already answered some of the questions I was going to ask, so I'll have to be quick on my feet. And Dean, this is your first time here. Everybody else has been on before, but I'm really, really glad to have you here. And please introduce yourself.
Sure. Well, thanks for inviting me, Scott. I'm Dean Donahue. I'm a thoracic surgeon at Mass General Hospital in Boston. And I've been doing really thoracic outlet surgery and treating thoracic outlet patients almost since I joined the staff about 25 years ago. It was more timing. The two people in the hospital who did TOS were both retiring. And so my chief at the time, Doug Mathieson, asked if I would kind of try to take this on and grow the program. And I mostly realized how much I didn't know. And so I really just tried to talk to patients for a while and listen to them carefully and read what I could and just kind of organically develop the program. It's we're really still a work in progress, I think. I think I have a lot of experience, but I don't know if anyone has expertise. I certainly feel I don't, but I do really enjoy the challenge of trying to figure this out.
And you've really grown the practice. You're incredibly busy and experienced.
Well, thanks.
So here's my first question to everybody was, how did you get involved originally with TOS patients? And since you've all kind of touched a little bit on it, I'll just ask if you can remember anything from medical school. And if not, what was the first patient you saw with TOS? Rob?
So my interest grew as I became more and more interested in peripheral nerve surgery. My background in plastic surgery, and I'd done both a hand and upper extremity microsurgery fellowship, and then followed that with a craniofacial fellowship. So that TOS soon came on my radar as a predominantly a peripheral nerve problem, and that was kind of the seeding of my interest. And so as we developed that, I still remember my first case that we did surgery on. It was a gentleman who was a motor vehicle accident, classic to what we see now. It's really the most interesting part of my practice that I see.
Fareed, how about you? Do you remember your first patient or where your interest just started?
Yeah, actually, it's an interesting story. I trained at the Mayo Clinic, and the last year, some of the fellows are given the honor of being the Claggett Fellow. It's a traveling fellowship. And I went to see this man who, before Dean, was the giant of this condition in thoracic surgery, at least, Dr. Hal Urchel. I spent 6 months with Dr. Urchel, and it was a humbling experience, I must say. It was amazing. He was an amazing surgeon, and it really just beginning of my career, I got interested, but also really understood how much we don't really understand. That was the power of Dr. Urchel. Was he had done, I don't know, like 1,500 of these or something like this, and he continuously told me that he didn't know enough, and it was and so that was the exciting part for me. And so that's how it developed over the years, and we'll talk about it more later.
Art?
Yeah, so I got into, as I said, TOS kind of through a back door. I've been doing minimally invasive spine surgery, doing approaches around 360 degrees around the spine for 20 years or so, and then really just somebody approached me and said, "Hey, listen, I got this patient who's got a really nasty cervical rib and hand weakness and things like that." And I'm like, "Oh, I can take like this." It's if you look at it, like I've done a lot of thoracic tumors and a lot of perineural tumors. It was exactly like a tumor in the sense of the physical approach and the osseous. So we did it. We published it. She did great. She went from like being really disabled. She couldn't even put her arm out the car window without really disabling pain, to being able to run marathons again and start getting her hand strength back. So, and this was after atrophy. I mean, this was a pretty far along case. And so then I started seeing more and more. And it's like so many, I mean, you guys, I'm sure, see it all the time, is that the more you get into something, the more you see it, the more you recognize it. And I actually say, seeing is believing, but believing is necessary for seeing. And TOS, unfortunately, is a condition that most practitioners don't want to even believe it because it's complicated. It's not easy. It's not a quick fix. And so most of the people who could be getting more interested in it choose to go to treat primarily the simpler stuff, the stuff that, passes through your practice quickly and move on to the next patient. Whereas TOS patients they're very, like Dean said, you got to listen to them. You got to understand them. You got to figure out what the problems are. And it's not it's not for the faint of heart or for the people who want a quick fix.
Right. Good point. It's amazing. There's still any controversy at all that it exists. I find that fascinating. So part of my practice has been over many years just to get to know people, to make connections with people who I can discuss and listen to and learn from. And from that point of view, it's been a blessing in my professional life to have this kind of academic challenge. Dean, you've been doing this for 25 years. You have an incredibly busy practice, incredibly well-renowned practice. Can you go back and blow off the cobwebs? Remember your first patient or first experience?
So I can't remember my first patient because it would have been during training. And I have to say at the time, I never saw myself being a thoracic outlet specialist. But I do remember the Dr. Lefferts, who was an orthopedic surgeon here, who was one of the two very busy TOS surgeons at Mass General. And just going into, I was an intern in ortho, and going into his room, and he just described it as I was trying to look, as he was doing a transaxillary approach, that it's an operation done by one surgeon with one eye. And you really just couldn't see much of anything. And just thinking, as I would kind of continue through my practice or through my training, that there really just had to be a better way. I mean, it seemed like everyone who did this really struggled, and I can understand why, but I just remember that really has left a mark on me. The kind of, even the experts would kind of struggle with this.
Yeah, and that's a great point. I think we all realize that there's stuff we don't know and there's stuff we can do better. All right, I'm going to go to the next on my list. What methods and tools, I'm talking clinical, otherwise, do you use to diagnose a patient with TOS? Rob?
So I think everybody's hit on a little bit of the story and the mechanism. And we always talk about listening to what the symptoms are, what's the distribution of the symptoms are, what was the onset and the mechanism. So that history is all very, very important. And then a focused physical examination. Most of the time we can get, to the point of that being our working diagnosis. Sometimes I'm sure all of us, everybody on this panel is quite thoughtful about how they're making a diagnosis, and then stratifying them to which kind of care pathway. And you're often ruling out, you might be working at the same time as the spine surgeon to make sure you're not missing some cervical disc disease. You may be working with the shoulder surgeon, and you may be even complicated by some level of downstream or more distal compression neuropathy. So I think, as Arthur was saying earlier, it's kind of a multifaceted of kind of making a diagnosis.
Fareed?
Well,
I'll just add real quick.
Imagine this is a long discussion. Sure. Go ahead.
Oh, no. So, sorry, I left out kind of the tools. We've fallen to, once we get to that point of the working diagnosis, and it's kind of established that we have a specialty visit with our physical therapist. We do electroddiagnostic studies, not to diagnose NTOS, right, or thoracic outlet syndrome. We do that just to make sure we're, another layer of not missing radiculopathy and downstream compressions. And then third, we do obviously an MRA study as well.
And what about your injections, Rob?
Yeah, that was very interesting. As a peripheral nerve surgeon, I was starting to utilize ultrasound very early, kind of mid 2000. And so born out of necessity of kind of efficiencies and really kind of wanting to understand the pathology better, I do my own ultrasound guided injections where we're injecting scalene muscles, we're hydrodissecting even that interscaling portion of the triangle, even hydrodissecting upper, middle, and lower trunks, and depending on where you are on kind of the pathway of the temporal sequence. If it's early, we're utilizing some steroid in that halo around there to try to soften up that fibrosis that's forming. We may utilize some Botox and the scalenes, can all vary early on versus chronic, which our results on utilizing those things are less, and still the diagnostic component though has always been beneficial for us. And in peripheral nerve surgery, just in general, I'm a big believer in blocks because for me, it's just kind of supportive information for our diagnosis, but it's also really important for the patient's confidence, as if they have a period of relief. I like that in my work.
So for our listeners, you take your best clinical judgment as to which nerve is involved and you block it. And if you get relief of symptoms, you're pretty confident that you're right on.
Yeah. And so that's our best, I think, at least in our practice, one of the best prognostic indicators that further treatment or even surgery will benefit.
And also for our listeners, if you'd briefly describe hydrodissection and what it means and how you approach that.
Well, just when you're injecting a fluid, whether it's saline or 1% lidocaine, around a nerve that has some scar down it, think of a shrink wrap on it, and what you're trying to do is push fluid in around that plane around to separate those two layers. Like I said, if it's early on and that scar is forming, that steroid tends to help soften that and reestablish the gliding surface and diminish the pain. So we've had pretty good luck with that, and it's worked in our hands. Again, just like everybody else, just trying to be thoughtful on diagnosing and treating these patients.
Thank you. That's a great description. Fareed.
Well, I think at the outset, it's important to discuss about the fact that obviously this panel knows that there's so many different types of patients who are put under this umbrella of TOS. My special research interest is in a very, very small area of this, and it comes really from the time that I spent with Dr. Urchel and kind of followed up on a lot of our work at that time. So there are two pieces that intersect in our practice. One is Dr. Urchel, after doing so many of these cases, always stressed the fact that there was, during an operation for removing the first rib, you had to remove what he called the costoclavicular ligament. To be honest, I never saw this, to be frank with you, but this is something that he insisted on, but he could see it down the tunnel as you did the axillary approach. So one part of our research in the last 25 years has been really trying to identify what is the anatomic counterpart to this costoclavicular ligament, which now we've written about this extensively. We can identify on MR. It is the costosternal joint between the first rib and the sternum that we think is abnormal in a subgroup of these patients. And that's really the counterpart to what he used to talk about. So that is an important piece. The other part of our research has come from the direction that, again, most of the panel, everyone probably knows this, and the audience should know that radiculopathies now are turning out to be not compression of nerves in the majority of cases. Whether it is, the sciatica, whether it's the lumbar area and so forth, it turns out that the majority of them, based on a lot of good work from France, there is compression of the veins that drain those nerves. So it's not something pressing on the nerve, but it's something that's obstructing the venous flow from the nerve sheath that causes this. So we've been very interested in the disputed TOS patients, or where it's not clear what's going on, understanding whether they have congestive disease from compression of the subclavian vein at the subclavian innominate junction, where this costoclavicular joint sits. And frankly, that's the area we work on. So again, this disease is multifaceted and certainly requires many different directions. We heard some from the neurosurgical standpoint. We're going to hear about others that are done in different ways. But for us, the group of patients that I deal with are people we diagnose an abnormal joint on an MR study, and then also the MR study, and not to really harp on the good MR, which is done by my good colleague who's asking me questions, but really an MR study that shows everything in the neck and the chest and so forth. So it clarifies to us that there's no other abnormality. And then on that MR study, if we see the abnormal compression, extrinsic compression of the subclavian innominate junction, those are the patients we operate on. And then the third piece that's come in the last, and I'll stop in a second, the third piece that's come in the last 15 years is the removal of that portion of the first rib that we see doing what it's doing with robotics through the chest. This is absolutely investigational and really a very different view of this disease, or at least the subset of disease. But the amazing thing is that now we have close to a couple hundred of these operations, and the results have been very pleasing. So I think that for this subset that's been sort of the enigma, we are getting some answers. So that's where we are.
So for viewers, the subclavian vein, as it tries to get back to the chest, gets obstructed right where the collarbone kind of matches up close to the first rib. And if you block that vein, the venous pressure, although it's low, in the arm, it's just a little too high. And the nerves see this increased pressure and they get damaged. There's some, as we've discussed, there's some animal models and human models on this. And we don't know right now how much it causes and how much it contributes in cases even with mechanical compression. So what you're doing is you're trying to free up this space. Do you ever do direct venograms? Do you generally tend to just favor MRAs to make that diagnosis?
Well, our experience has changed. We began with venography. Again, the other interesting thing to us is that of course, these patients kind of cross over to the Paget-Schroeder patients who come with clotting of the vein. And it's fascinating that in our studies where we have questioned the Paget-Schroeder patients about their neurologic symptoms before they got the clotting, which they never even realized was occurring, in retrospect, they talk about a lot of issues with their extremity before they got the clotting, which brought everything to the forefront. But we started with venograms. That seems to be quite invasive, frankly. And then, you know, when I was in Arizona, I worked with some of our excellent imaging colleagues and now with Dr. Verdun. But the bottom line is that we have good MR studies that can clearly show what we're looking for. One of the important things is that you got to be looking at the right place. So a lot of our colleagues in imaging have to kind of rethink about how they read these MRs because we're looking for a specific abnormality. And many times the MRs are read that are read by the conventional people that they kind of miss what we're trying to diagnose. But with someone who is trained in the MR for TOS, the MR has been incredibly successful in terms of predicting surgical outcome. Now, it is important for the audience to appreciate that we're looking for surgical outcome and kind of working this backwards and saying, okay, you had TOS, neurogenic TOS because you got better. That is not pure science. So let me be very clear about that.
I'll bring up, because you kind of hinted at this, but there is a McCleary syndrome, which doesn't get much press or much discussion, but it's basically occlusion of the subclavian veins without the blood clot. Symptomatic occlusion of the veins. And patients get a syndrome very similar to TOS, but they don't have blood clots. There have been a few studies back over many decades of people trying to measure the central venous pressure as patients move their arms, doing venograms because that's what they had at the time, but also measuring the pressure. So there's been evidence in the literature since the 1930s, at least, of venous compression and congestion contributing. So it's great that you're doing this. Art, I'm going to go on to you next. What kind of methods and tools do you use to make the diagnosis of TOS?
Well, obviously, like everybody else said, you got to listen to the patient, and the story has to start making sense for you to start even investigating. I rely a lot on my physical exam in terms of the common triggers and the points of either physiologic problems or pain or pressure. I also I actually, my suspicion tends to go up when patients have other associated syndromes that I find to be, strongly correlated with what we would consider a good TOS story. And then this is actually going to get back into what Fareed was just saying. So a little spoiler alert here. So I will look into things like Ehlers-Danlos syndrome. There's a lot of patients with ligamentous laxity, patients with certain types of congenital anomalies, including congenital anomalies of the rib itself, where the rib may have extra flex because it's not a single piece of rib, but it might be a bifurcated rib, either congenital or traumatic. And one of the other ones that one of my vascular colleagues, who's one of the mavens on this particular entity, is called May-Thurner syndrome. It's a venous occlusive disease in the pelvis, but he found that there's a huge percentage of patients with May-Thurner who also have TOS symptoms. And interestingly, when you stent the venous occlusive disease in the pelvis, the TOS seems to get better in a lot of these patients. And this gets back also into what we see a lot, is that some patients, you do a right-sided decompression and the left side feels better. There seems to be, getting back to Fareed's point, more than just the subclavian vein involved in the ischemia or in the irritation of the nerve itself. It's a focal, almost like a plexus of veins. And this is part of, it's like the caput medusa. It's like the venous bypass of an obstruction dilates other collateral veins, and that these veins can get engorged and can irritate. Or if you have insufficiency of these veins, you get, like in the neurologic syndromes, we see neurogenic claudication is the classic example of a vascular insufficiency causing nerve irritation. So looking at these other associated syndromes that may increase the likelihood that they are having symptoms from a problem in the thoracic outlet region. One of the things that I've been trying to get more of my colleagues interested in is this concept of the neuro testing for these. We all know that, as Rob said, there's EMGs are useless for diagnosing acute or early TOS. It's just for excluding other non-TOS causes of these types of symptoms. What I have been trying to do is to get people to be able to do SSEPs preoperatively on patients as a diagnostic tool, because intraoperatively, these have been shown to be sensitive, much more sensitive than EMGs are for ischemia. And I actually did a proof of concept of this in one patient.
For our viewers, will you describe this as somatosensory evoked potential?
So somatosensory. So there are a number of different types of evoked potentials. There's motor evoked potentials where you actually shock the brain either through electrical or magnetic stimulation, and you're actually recording the physical movement in a limb downstream. And then somatosensory, where you're recording over the somatosensory cortex, you stimulate the skin in a particular nerve distribution dermatome and record brain activity from that peripheral stimulation. And this is a way of checking conduction throughout the entire neurologic system. From point A to point Z, you get the whole sequence with these two, and especially when you're doing it bidirectionally. And so it can be very useful, but it's also kind of a noxious study. I finally got somebody to do an awake SSEP patient. They did it actually down in Atlanta, but they didn't do it with the arms up like I asked them to do. They only did it with the arms down, and they said it was a normal study. And I'm like, no, the patient's symptomatic with their arms up. Why would you not do it? And so anyway, but so I do think that there are some additional tools that hopefully in the near future we will be able to take advantage of that will be a little bit higher yield in our diagnostic toolbox. Obviously, imaging is very helpful. Although I know thoracic surgeons who say they don't even bother getting imaging. If the story matches, they go right in. So, it's one of these things where, I like to be more of a sniper with a high-powered rifle than taking a shotgun to an approach. But I also, these people, sometimes they help people that you might have had trouble imaging a problem that, people would be afraid to dive into. So I'm not saying which is the right way approach, but that's
to
mine.
touch on that lightly. I can just say that our level of knowledge as a radiologist is really kind of in the basement right now. And so I see a lot of reports of MRIs of the brachial plexus that go out to clinicians. And to my eye, because I'm also trained as an internist, they're just clinically useless. And so I think a lot of doctors have become shy over time at even, wasting their time with that. What I'm hoping through collaborations with folks like you is really to at least raise the value of it. Clinical tests for TOS aren't great, and they don't show all the different variants. So the bar to do better hopefully is low enough that with imaging we can add something. And of course, MRI doesn't produce any radiation for the patient, so it's not a risk in that regard. I did want to touch on one thing, actually, two things you said. Does anybody ever get an EMG with the arms in provocative positions?
So it's been done, and in fact, actually, we had this exact discussion with Dr. Newkirk almost a year ago, I think, and he said he did it, and he said he saw no difference. He said and you know how he feels about TOS,
Yeah.
but he says it's of no clinical utility, even though you would think intuitively that would be the place. I will say that in the case that I did in the operating room with the monitoring that I was describing,
Mhm.
I had the patient flat on the table with the arm down. I had the patient then I with the patient asleep, but while we were doing the SSCP and MEP monitoring, I moved the arm to the up position, but it was just in the supine position. It was flat. It was not under gravity. And there was no change in the monitoring from arm down to arm up without gravity. Then, because the arm weighs about 8 pounds in an average sized person, I put about 8 pounds of downwards traction on the shoulder joint with the arm up. And immediately the SSCPs and MEPs started to drop down. And then when I put the arm back down again, they went back to baseline.
Wow.
So I thought that, and one of these days I'll get around to writing that up, but it was a fascinating difference between, and the EMGs did not go off in the different positions, and there was no change until I put the downward traction to simulate the weight of the arm in, as you've heard, so many people on this thing say, this is a disease of reaching.
Right. I have a collection of 5 papers from the 1960s that did direct arteriograms. For our viewers, that's where they actually put a catheter in the artery and inject dye and take x-ray pictures really quickly. And they found that these patients who were either lying flat or sitting up, that once they sat the patients up, that the impression or compression of the arteries increased. So one thing I can't duplicate with MR right now, but there's clearly an effect from gravity, which coincides with what you saw. And you mentioned Dr. Newkirk. For those of our viewers who don't know him, he's a neurologist in the San Francisco Bay Area he's now retired, but he had seen patients for 40 plus years with TOS. And he, according with what Fareed said and what you're saying, he would always bug me and say, we got to find out what's going on with the veins, because I get a certain proportion of patients who have lower extremity symptoms. And I'm sure it's associated with their TOS, because when we treat the TOS, the lower extremity symptoms get better. And we talked about it endlessly. I remember pulling up papers on the venous drainage of the spinal cord. And there are several internal and external venous plexuses of the vertebral column, but it all seems to drain mostly up into the head and then down through the neck veins, which would mean if you affect the neck veins, you're theoretically affecting the venous emptying from these plexuses around the spinal cord. Could that cause congestion? There's no proof of it. It's just a fascinating thought. So thank you for your stimulating thoughts on that. And Dean, I know you've been waiting a long time. I'm glad you're still with us. So what tools and methods do you prefer to get you on the path to diagnosing patients?
Well, like everybody, it really is history and physical, I think, are the kind of the foundations that the rest of the house is built on. So, trying to get a detailed history and try to do a thorough exam. I do favor imaging studies. We've sort of in-house, we designed a specialized CT angiogram and an MRI protocol that I find very helpful. It doesn't make the diagnosis. I tell my patients all the time, I wish it were that easy. But I do find when you understand somebody's anatomy in as much detail as you can, and you know what their symptoms are and you know what their exam shows, it just sort of helps me put the puzzle together a little bit. It's never completely together, but I do find it helpful. We also do a lot of injections, trying to inject the anterior and the middle scalene muscles and the pectoralis minor muscles. And I'd say 20 years ago or so, we were doing lidocaine injections, and we switched to Botox by about that time. We've been doing Botox for a long time, and again, there is no test for TOS. I wish it was that easy, but I do think that Botox does a couple things. One, it becomes a useful tool in a lot of patients for their treatment strategy. About 7 out of 10 patients that I send for Botox will get some degree of response, and sometimes it's dramatic and very long acting, and sometimes it's less so. But it can be an important part of the tool. But it, at the very least, it kind of gives me a sense of, is there a component of reversibility? The problem with Botox is I think it's at least when in the public, it's kind of misunderstood. It's thought of as just kind of, decompressing the thoracic outlet, which I think that's one of its mechanisms, but it blocks nociceptors, which are the unmyelinated pain fibers within muscle cells. And so it's conceivable we're just giving a really good long-acting pain medicine. It inhibits the release of certain neuropeptides that are important in the pain cascade. And so it has to be taken with a grain of salt, but I do find it very helpful, not just as a tool for diagnosis, but also as a part of a patient's treatment strategy.
Are you saying that the anterior scalene muscle is a key part of TOS, if I can take the liberty rephrasing?
I think it's a part of it. I don't know which is the key, but we would do just the anterior scalene for years, and we added maybe 5 years ago or so, we started doing the middle scalene. We would traditionally do the middle scalene for apophysomegaly of C7. So if there was a cervical rib or if there was an elongated transverse process, we would do the middle scalene as well. The thought being that the middle scalene, one of its slips is on the transverse process of C7. So oftentimes with those bony anomalies, that's a very kind of a thickened cord. So we would do the middle scalene as well. It's a harder injection, but I think our radiology team has done so many of these now that they're quite slick at it. So we routinely do both the anterior and the middle, and the pec minor muscle as well.
In every patient?
No, but a fair number. I mean, I mostly because I figure it's really hard for us to predict. It's hard for me to predict who's going to respond and who isn't. We really tried to do that, and there's no sign that I've been able to identify that predicts a responder to Botox versus a non-responder. And it may be because the response rate is fairly high. It's about 7 out of 10. But if I really think that a patient that I'm seeing we're really on the wrong path, then I'll just try to get them on a better path early on. But I think most patients, by the time they kind of work through the filtering process, and a lot of them I think are reasonable candidates.
And have you ever done pec minor by itself?
Pec minor Botox?
Yep.
Yes. I don't think it's as high a success rate. Maybe because of the size of the muscle, I don't know. But yeah, we have done isolated pec minor injections. Back when, if we would do let's say a rib resection and a scalenectomy and a brachial plexus neurolysis, then if a patient improved but still had some symptoms that I thought could be related to a pec minor compression, then we would do the pec minor Botox. It never really seemed to add a whole lot. If they didn't respond, but I was very suspicious, I would end up doing a pec minor release, and a very high percentage of them would get better. And if they did respond and I was suspicious, then we would operate on them. So it kind of didn't become a good predictor. If I was clinically suspicious for a pec minor after a rib resection, I don't think adding the Botox turned out to be all that helpful.
So
I don't really try to push anybody into surgery. So I'm open to, trying to treat someone with Botox as long as it's effective and as long as they want. We definitely have had many patients who've never, most of the people I see do not end up getting surgery. And I think there's lots of different reasons for that, but I do think the Botox injections are a big part of that.
Great. What percentage would you say of the patients you see that do end up going to surgery?
The overall patients that I see, well, if I factor out the percentage of venous cases that I see that go to surgery is over 90%. I just think most people with venous TOS are surgery is the appropriate thing to do. For neurogenic, it's probably close to about a third.
Huh.
Somewhere between 25% and a third, I would bet.
Interesting. And then I just want to give you kudos for getting your radiology department to work with you. I always say this art says it takes a team. but
Yeah.
clearly, it's great that
absolutely.
you've got a multi-specialty group helping with that.
Yeah, no, it's been very helpful.
Awesome. Now, my next question is, what surgical approach do you use? And I don't want you to be too technical for our viewers, but briefly talk about your approach or your preferred approach and advantages, disadvantages. And Dean, I'll start with you and go backwards this time.
Oh, well, I can honestly say I've done every single approach that I'm aware of. I've done supraclavicular, infraclavicular, paraclavicular, posterior approach that Dr. Urschel favored for redos, robotic. And I for me, the operation that works the best is the supraclavicular approach. I do it through a fairly small incision. It's about a 4 or 5 centimeter incision. And I really do believe, I'd say as a mantra, is to be very conservative about who you operate on. But if you're going to do the operation, I think you should be very aggressive. And again, this is just what works for me. I wouldn't pretend to have the answers, but what I've learned, and I guess probably from doing a lot of redos, is I think taking out most of the rib is important. And again, I'm sure people get great results without doing that. I just would say, for my practice, that's what's been very helpful. And so I go all the way back. I leave a small part of the head of the rib because I don't want to disrupt the stellate ganglion, but I disrupt the costotransverse ligaments and really try to take out most of the transverse or most of the neck of the rib and just leave the head of the rib there and take it out to the cartilage. And then I try to do a fairly aggressive scalenectomy and a full mobilization of the at least the trunks of the brachial plexus. And depending on the symptoms, sometimes either the suprascapular nerve or the dorsal scapular nerve or the long thoracic nerve. But that's a small minority where I'll kind of chase peripheral nerves out. But if I'm suspicious, then I'll certainly explore them. And if they're scarred, I'll completely do a release of those nerves as well.
Wow. So how far you get? Very far posterior, leaving just the head. How far anterior do you get with your approach?
I don't want to disrupt the mammary artery, have some future heart surgeon get mad at me if they ever need it. So it's just lateral to the mammary. I try to get to the costocartilage.
Do you get to the subclavius tendon? Do you ever look for that? You do.
Yeah. Good. It's the subclavius muscle. Well, it's kind of muscle and tendon. I don't know that it's at least how I see it. It's kind of all kind of one structure. But yeah, we release the subclavius, and I get right to the costoclavicular joint, and I probably do take part of the costoclavicular ligament that Dr. Urschel had spoke about. But I also don't want to disrupt the sternoclavicular joint. One of the things, I help the orthopedic surgeons here with a fair number of sternoclavicular reconstructions for chronic dislocation. And so you can create instability of the clavicular sternal junction, and I don't want to do that. But I think you can certainly disrupt part of the attachment to the first rib and the costoclavicular joint.
And then when you do scalenectomies, you said, I believe, just scalenectomies, clearly anterior. What about middle? How much of the middle scaling?
So probably about 3 centimeters of middle scalene if you were to measure it from the attachment of the first rib. And you have to be careful because both the dorsal scapular and the long thoracic nerve perforated. And I don't want to create an injury. I don't know how much is really necessary to take out. The goal, I think, is just to create as much space as I safely can. And so that's why I try to do as an aggressive a scalenectomy as I can without creating a problem.
Right. And those nerves are variable. They branch differently, right? It's
correct.
Yeah, that's a great description. Thank you so much.
Sure.
Art, how about you?
So the two procedures that I do, one is the infraclavicular, much as and I'd love to talk with you sometime offline. Just pick your brains about the things you've learned over the years about this. One of the things I've learned is to be a little less aggressive with how much of the costoclavicular ligament I take, because I've had a couple of patients who have developed sternoclavicular instability and pain from that. And I think the EDS patients, these collagen vascular patients of various ligamentous laxity are more prone to that type of a problem. And so what I do is I come, very similar to what you do. I come right in forward over the first rib, go straight back. I use some very fine retractors and just basically push the rib down to push the retractor further back. And I get past the middle scaling muscle, detach it completely. I don't go out quite as far back as you do, mainly because if I think I need to go that far back, I'll do it from the back as well. But yeah, so I do an infraclavicular very similar to what he does, and just trying to make sure that we impair the normal anatomy as little as possible, resecting the rock from the rock in the hard place that the neurovascular bundle is being squeezed between. And I find that getting back a good 5 to 7 centimeters straight back is really what seems to do the most. And this is from some of the 3D modeling I've done of the CT angiograms. Unfortunately, Scott, I haven't been able to 3D model any of your MRIs. So the CT angiograms are much more effective for putting into it. And when you look at the difference between the arm up and the arm down position and the rotation of the clavicle and backwards, as well as the direct motion, that's 5 to 7 centimeters seems to be the sweet spot for getting past the point where the compression tends to occur.
Thank you. Fareed, yours is going to be one of the most interesting approaches.
Well, for the audience, I think it's important to start with the point that, at least from my standpoint, this disease, I see cervical disease differently than I see thoracic outlet disease. I think that really should be very clear that there is nothing I do that can affect the cervical disease, and whether there's a rib, there are bands or anything. We are talking about, as Dean said, he operates on a third of the patients and of the TOS type patients. We are interested in the other 2/3 as to what percentage of those patients have some disease that's related to the vein as we described. So this is a subset of a subset of a subset. But so the only patients that we would operate on, or that in our program, would be ones where the MRA showed extrinsic compression of the subclavian innominate junction, period. Now, those patients, they are not the Paget patients. The Paget ones, as Dean said, they need surgery. That's the easy, that's the low-hanging fruit. The neurogenic patients that have been called disputed for various reasons, if we see that specific pathology, and by the way, we have found now, again, after many, many years of this is bilateral disease. It turns out to be a congenital abnormality of the way the chest formed. This is a different disease than compression of the brachial plexus by other actors in the thoracic outlet region. So it's really important to tease out these patients and have a specific reason for doing a specific operation, instead of the shotgun approach like we heard. So that's not a good idea. So the issue is, here's a patient, they have had a great workup, have seen lots of good people, and basically now the MR is the only thing that we're looking at, and the only thing that we see on it is compression of the subclavian innominate junction. By this, you can see the abnormal part of the bone. And again, we have looked at these patients retrospectively, comparing the resected bone to normal first ribs, and they have a tubercle in that location that's compressing the vein, and it gets worse when they move their arm. So you can see all of that on the MR. The approach we take is basically a robotic, and it has nothing to do with whether you can do it with a robot or not. It's just it's something that we do. And frankly, the robot lets you get to that joint area very easily. And we do this articulated. One of the advantages I can tell you, and my colleagues have said this, you can disrupt the clavicular sternal joint, but with a robot, you get away with just taking out the costosternal joint and not disrupt the other one. So that's an important thing in my own experience, because when I did it the other ways, we had issues with the other joint. So that's one thing. The other thing is, we have done a study in this specific subset where to understand how much of the rib should be removed. So we started our experience with the rib resection, the way Dean described, all 95, 98% of the rib and leaving some behind for good reasons. And then we slowly moved more medially to just medial to the subclavian artery. And again, we're not trying to decompress the brachial plexus here. We're trying to decompress the subclavian vein. And it turns out that there is no difference in the results. In fact, some of the complications are less in terms of disrupting various nerve structures in the back. And so basically right now, we would do a resection of everything medial to the subclavian artery and disarticulate the joint. In these people, I think disarticulating the joint is really important. And I say that because we have a series of redo operations where the patient had a first rib resection by very excellent surgeons. And then when they did the MR, they had compression of that area on the MR. And we couldn't see too much on CT and so forth. But when you go in, you'll see about a couple centimeters of bone at the costosternal joint still intact because it was cut just before that. And when you remove that, these patients have gotten better. Their symptoms, and I must say, their symptoms got better after the first operation, but wasn't perfect. And then when you remove that and you can see the vein just pops open, then those patients' neurogenic symptoms got better. So again, a very select group of patients, highly, we're sort of almost setting ourselves up for success, because if they don't have that finding on an MR, they're not getting an operation. So, you're almost fixing the game. So I want our audience to understand that this, that's a really important part of what we're doing. So this doesn't apply to everybody with TOS.
Right.
But
And what you may be describing is there are certainly patients with different forms of TOS, and you could well be taking these patients who had both compression of the plexus and this congestive neuropathy from congestion of the veins, and they needed both things resolved.
They may, but I think the way I see it is by the time the patients come to us, they have actually seen so many different people and so many excellent surgeons. So if the thing was fixable, it would have been done by the time they come to see me. So we, again, highly select these patients to the point where we're dealing with a subset of TOS. But the results seem to bear this kind of thinking. Thank you.
And because I've had the opportunity to watch your surgery, I just want to emphasize, I think this is true, that your target right off the bat is to start at the anterior part of the first rib at the costal cartilage. Is that fair?
Yes, it's fair. And again, I think that these are different patients than the ones who have other conditions that we know about. And then, and it's fascinating that, again, in retrospect, when we look at these patients, just like it was said earlier, they have other congenital abnormalities. This seems to be a congenital disease that shows itself when the patient's bones become more solid, calcified, etc. Because the youngest patient we have is in their early 20s. And so if we think it's congenital, something is changing, obviously, to bring up the symptoms. But it is fascinating that it's bilateral. The patients, when you do the bad side, they can tell the difference. Whereas beforehand, one side is so bad, they think the other side is normal. So that's been an interesting finding. And then the other thing is we see, for example, a number of patients we've had with Eagle syndrome, whether you believe it exists or not, but they, so that's again a congenital venous compression. So it seems that these venous, and then as was mentioned with compression, venous disease of the lower extremity, also how it works, I don't know, but the bottom line is that I think we're dealing with a subgroup of patients with specific bony abnormalities and vein compression.
That's great. And I will point out something which I say, and any of our regular viewers know I always say this. When Pete wrote the paper in 1956, coining that term thoracic outlet syndrome, he had an introductory paragraph that basically said, there's all this complex anatomy. It's different between every patient. There are different causes of this. So let's just lump it together. And I think my job in this is to help, along with other people who are experts like all of you, to help start unlumping. I think there are different things going on here. And when we lack understanding, it's because, as you said, Fareed, you're aiming at a very specific subset, and they'll behave differently than the next subset. So I think there's many types of TOS, and I think that term needs to be viewed that way. And Rob, you've been waiting a long time now. I hope you can still speak. I want to know about your favorite approach and advantages, disadvantages, please.
Again, learning just from everybody and all the thoughtful comments, and especially the Fareed, your Venus, has made me think about even further stratifying my model. But you know, from the beginning, that was kind of one of my goals, is to, so hey, you know, we have these other peripheral nerve pathologies throughout the body that we've really worked on trying to stratify care, even stratify surgical care to best meet the patient. For instance, an ulnar nerve at the elbow, right? You can do it as an in situ release, you can do it as a subcutaneous, or you can do it as submuscular transferrin, right? And so each one of those different patients will command different types of surgical techniques. Now, I function as a peripheral nerve surgeon. I function predominantly in the neurogenic thoracic outlet, but as we all know, they all overlap. You have to have a good understanding of all of them. But we also know that 95% are neurogenic, and so how do we begin to stratify and think about that? And I think we started to talk about this earlier about just kind of the difference between the scalene triangle, the costoclavicular interval, and the subpec minor space or choroid space. And from my standpoint, what surgery I do and what approach I use really depends on what, if I think they have one or all three of those, and try to stratify care based on that. And I think in my practice, at least the ones I see predominantly are those who have scalene triangle and pec minor. And so 9 times out of 10, I'm a non-rib removal person, but 1 time out of 10, we are. And again, so when we're addressing surgically just the scalene triangle, much like everybody else, we do a subtotal resection of the anterior scalene, mineralizing the plexus, and I do a release, a complete release of that middle scalene off of that, as we, you know, that broad insertion that kind of wraps around to the front and can act like a fulcrum. And then on most every patient, I try to be very thoughtful and specifically look at that dorsal scapular nerve, long thoracic nerve, and that suprascapular nerve as well as really, I call it, those nerves to me are part of the scalene triangle syndrome component. Preoperatively, and then and just I'll talk about the pec minor release, make an anterior shoulder incision, release the pec minor, make sure you get that lateral fusion, release the clavipectoral fascia all the way up, and then even added in that division of the subclavius muscle, which is a clavicle depressor as well. And then preoperatively, over the years, we've gotten better and better at just kind of determining which persons truly have a costoclavicular compression component, because in those patients that have a high index of suspicion for, obviously we're going to do the rib resection. When I do that, I usually do that with Dean. You probably know the guy, Josh Baker, who is now here in St. Louis, and work with Josh. He's just a tremendous guy.
He's excellent. Yeah.
Yeah. And just really been fun to be, kind of putting some thoughtful pathways and doing with him. We'd start out, we just said, hey, we could either do it, we'd start doing them together just to see who, and we've continued to do them together. And so quite fun for both of us. And he's really made me think about some of the other arterial and venous things that he's have a bit of a growing interest in as well. But so preoperatively, if we can determine that if there's a clear costoclavicular component, then obviously, but it's in a smaller portion. And then if I think there's this, for me, and this is a topic we can all discuss, but probably don't have enough time to discuss tonight, but if you think about, if you release both the scalenes off the first rib, that first rib's going to actually drop a little bit. It's not a whole lot, but it will drop some. And then if you release the clavicle depressors, such as the pec minor and the subclavius, you're allowing that clavicle to drift up. So your net effect is that you have a gain in that area. So there's a certain patient population that say they have some level of that compression that are going to be the rib removal will be obviated by just the mechanical changes of that space. And then back to the scaling triangle. Early on, I had a couple patients come in and say, "Gosh, my arm feels so much better, but I still have posterior shoulder pain. I still have an occipital headache." And those patients, I started to try to think about matching up. The person that has that direct pain down the medial board of the scapula, the person who has scapular pain, or the person that has the pain kind of wrapping down at the axle and the chest wall. And those matched up with those. And so, I have a very, very low threshold to address all three of those, especially if they have any kind of posterior shoulder and axillary pain. Even I don't know if you guys see the folks that have the residual scapular pain can have that isolated suprascapular nerve compression at the notch. And I think one of the benefits of addressing that and just freeing up that scapula or suprascapular nerve, kind of untethering it, so to speak, off of the plexus and its sleeve, is that it gives more slack to that, and that nerve is not hanging underneath that notch. There's not pressure on it. So just even giving it a little less tension across that notch is
So you have patients with a suprascapular nerve entrapment type of syndrome, and you improve that at the scaling triangle. Is that correct?
Yeah, I mean, that's been my thought, is that, I think again, the sleeve around that plexus, right? The shrink wrap or the rind that's around that I think we probably all address and clear off, is tight. And as you unfurl that in some of those patients, I just think it must help in some of those cases, because there are some where it doesn't. They still have a suprascapular nerve entrapment because you just can't get the shoulder back up, or just a lot of things going on.
But
looking
you
at
also
that data now, so I don't know exactly the real number. Stay tuned, I guess.
You also address the clavipectoral fascia, though. So theoretically, you're reducing tension in multiple spots.
Yeah.
Cool. That's very good. All right, now I'm going to ask a little bit tougher question for different reasons. So what question should a patient ask before surgery, and how should a patient pick a TOS surgeon? Dean, you want to start with this one? I apologize.
No.
We just honestly, we get this question a lot from patients, and I always refer them, when I can, to good people like you. But what helps a patient make these kind of decisions?
I mean, I don't know how to recommend to choose a surgeon. I mean, I think it's obviously there's economic factors, because there's not a ton of people around the country that do it. So, just look at where we're from. We're none of us are very close together. Arthur and I from New York to Boston are the closest. So, the economic factors matter. I think, someone that has some experience with it, I think would be important. But that's not to say that you can't get a good operation and have a good outcome with somebody who's inexperienced. I guess it's still probably, I do think experience matters. And then the question that they should ask, I hadn't really thought of that. I get asked so many questions, and they're all good ones. I mean, I think a patient needs to be comfortable with their decision, with the surgeon's thought process behind it. And I think in the end, none of it, well, I can't guarantee that a patient's going to have a good outcome. I wish I could. I can guarantee them that I'll do their very best operation possible. I can guarantee effort. I can't guarantee a result. And so I guess I don't know what they should be asking, because I can't, the best questions I can't answer. Am I going to get better? How long will it take? Those are the real questions that they want to know, and I can't answer them. Maybe others can, and that's great. They know more than me. I just, I'm not sure what to say, the one question that'll help you determine if the surgeon is going to do a good job and you're going to get a good outcome. I think it's whether or not you have faith in them and trust what they're doing and trust their approach. I think that's probably the best gut feeling that you have.
Do you, and I'm not meaning to make this too difficult. So is there a question that you feel patients ask you the most about that decision to go to surgery versus conservative therapy?
No, I not really. I think maybe by the time we get to the process of surgery discussion, because we're not, it's not something I really talk about early on in our relationship. But as we get to the point of surgery, I think they've perhaps had so much interaction, not just with me, but with my team. I mean, I've got really lucky. I've got 3 great nurses who are phenomenal. I've got a great admin, and I'm the least important member of the team. They really are great, and they interact with them all the time. So I think most of their questions are probably answered by my team, and they know how I approach things, and they can give the same answers I would. But I think, usually it's sort of a process that's happened over visits. And so it's not, I can't think of the question I get asked the most other than, can I keep my rib?
Okay. And there may be something just taken for granted because of your organization, the level of care in MGH in general, and your experience, how much you've done this. That may be a question that patients just don't have to ask.
Well, they should. I mean, I tell everybody, I work for them. I mean, we work for our patients. They're the boss, and they have every right to ask whatever question they want, and we can just try to answer them as best we can. But most of the good questions, I think the answer is, I don't know. I can't be sure. Unfortunately.
Thank you. Art, how about you?
I'm also, I'm going to basically take what Dean said and agree with it 100% to the point of, the question doesn't matter. It's the way the surgeon answers that's the most important way to just determine. If the surgeon is like, there's only one way to handle this, this is the thing needs to be done, you're going to do this, you're scheduled for the 17th, and okay, next patient, that may not be the right surgeon for you. And so I think you want somebody like Dean, somebody like Fareed, who's going to take the time to listen, and is going to be there for them in the post-operative period as well, to make sure that things are going smoothly, and that if there are next stages. I mean, and the things that I always say is I don't have a magic wand. I have surgery, and surgery is a different abnormal position from what you are now. And the idea is to make it a less painful. I wish I could make this all go away like it never happened. I can't. What I typically will do is I'll try to manage their expectations and give them what I think is a reasonable degree of recovery that we are shooting for. But like Dean said, I can't promise an outcome. I can just promise you I will do my best.
Well, and you did bring up one point, which is about post-operative care. I think that differs between different practices, in my experience, from what I hear from patients. So that's a good question to ask. Fareed, what about you? What would you say are good questions people use, and how would they narrow down?
I can answer in the following way. What would I do if I were a patient, right? So I think that's that from my standpoint, that's key. And the way I would look at this is we're sort of a tunnel, and it's getting smaller and smaller as we go forward. So I think the patient should begin with people who will do a good exam, neurologists who will do all the various things in order to rule out, because this becomes a diagnosis of exclusion almost. So all of that good workup needs to happen. When they get to the point where they're entertaining thoracic outlet syndrome, I would suggest that they obtain a good MR angiogram, which maybe a good MR study is a better way, similar to like NeoVista, which will look at everything, because that will kind of lead you down different. I mean, we are 4 of us here. Each one of us deals with different parts of this disease, and the dean actually deals with a broader spectrum than there are other 3 people here. But so then I think that is very helpful. Then they would see someone with experience. I actually think it's very important to see someone who has experience. Taking out a rib is not the point. The point is understanding what's going on. And so I think people, there are experienced people, maybe, all around the country. You know, the deans, there's only one dean, but I'm sure there are a few people who are like him, to start with that aspect, with that level of experience. And then, as you can see, we're homing in on different areas of TOS, whether it needs to deal with outtaking a rib, like Rob was talking about, or whether it needs to do what Arthur talks about, or whether it needs to do what I do. So I think that that's the way it should go, as opposed to this approach, the same approach to everything. And then I would say that if you get to the end of the line, for example, so that everything has been done and still there are issues and question of TOS, that's when we would entertain the venous component and talk about what's happening to the vein. So let's say they see Rob and he does what he does, and then, you know, the patient still may have issues, which happens in a certain percentage. I think one message for me to give to my colleagues is think about venous congestion and see if that maybe is what's going on top of whatever else is going on. And then that's the kind of thing that comes to see someone like me. And that's pretty much the way I would advise someone to go.
Thank you. And Rob, for last, any contributions to that?
That's such great and thoughtful comments by everybody. I think just if I'm in the patient, I think, and what I've gathered from everybody here is if you're a patient, you should look for somebody that has experience, and that's, I always say, patient centric. We all know providers or surgeons that are like procedural centric. This is really a diagnosis where you have to be patient centric, because you want to be right for them, and then you want to do a surgery that helps them. And to Dean's point is that, you know, I always say that at the bedside, here's what I promise. I promise we're going to take our time and do the best job we can. And it's really meant that. So I think if you're looking for a provider, you look for somebody with experience, and you look for somebody who's patient centric. It's my only other 2 cents.
Thank you. All right. I have one more question I'm going to save to the end. That's an easy one, but we're going to take a couple of patient questions here first, or viewer questions, if we could, Herb. All right. Igor Thomas, you know, I just saw a piece in the movie Young Frankenstein, and I'm not sure whether it's Igor or Igor. I'm not making fun. It's just a very funny scene that's always stuck in my head. And I showed my kids. So they usually reject anything I find funny, but this one they liked. So Igor, I'm going to presume, during the surgery, the scalene is divided. What does that mean exactly? And what happens to the scalene that remains in your body? Well, the body generates scar tissue around it. Dean, do you want to handle this one?
So there's a difference, I would guess, between dividing the scalene, which I would say people would probably just, using electrocautery, just cut it off of where it attaches to the first rib, and then that will retract, and any muscle that is no longer being functional, and since the scalene has nothing to pull on, it can't be functional anymore. It's going to atrophy. But I think scar tissue forms no matter what we do in surgery. I mean, scars, it's inevitable. And so what I've seen in patients that I've done redos on, that have just had the scalene divided off of the first rib, is it seems to be stuck to the brachial plexus. Maybe that's totally inconsequential, but one of the things I do during a redo is just take out whatever scalene I feel is in the vicinity of the brachial plexus. And so if I'm doing that during redos, which is much harder, I want to do it during a first-time operation. So there's a difference between dividing a scalene and removing part of it. You can't remove all of the scalenes. I mean, it goes up to the C3 vertebrae, and you need Art with his fancy neurosurgery tools and techniques to get all the way up there. And it's not necessary, I think. As long as it's away from the brachial plexus and it's no longer doing its job, it's just going to atrophy because it can't function anymore. So I think that degree of residual scalene is probably not important in terms of long-term outcome or creating a problem. That's how the group has a different feeling on it.
I'll throw in 2 little points. One is that Adson did scalenotomies. This is just dividing it. And he did it for patients with cervical ribs. At the time in the 20s, they just had x-rays. They didn't have any fancy imaging. And so his thought was kind of revolutionary. Instead of taking out the cervical rib, which is more complicated, just divide, do a scalenotomy. But he had a lot of recurrences. We don't know why. The other thing I'll add in is that good MRI will show whether the nerves of the brachial plexus are wrapped up in that scalene muscle or going around the front instead of the back. There are a lot of variations in the pathway of the brachial plexus, and that would be one of the reasons I believe imaging is helpful ahead of time for deciding what needs to be done. My 2 cents. Anybody else comments on scalenotomy versus scalenectomy? Okay.
I think we all do either a subtotal resection. I think did I gather that from everybody? No.
I do more of an otomy. I don't usually go chasing it up. I don't want to. I try to stay out of the no man's land of places we don't belong.
Not Gugupa says, hi, and thanks for doing this. Thank you. Question, when you see periscapular pain and anterior scapular tilting as the primary pain driver, what surgical interventions does a surgeon consider to address this? Art?
So I would turn this question around, and I would say that the periscapular pain and the anterior tilting aren't the cause of the pain. They are caused by whatever the other syndrome is that's causing the scapula to tilt. The scapula is supported by 17 different muscles that each attach at various points, anteriorly, posteriorly, front, back, side to side, to the scapula itself. And so the scapula is driven by the relative balance of the, and tension on all of these muscles. The scapula itself does not make contact with anything other than the humerus and the clavicle. Those are the only two bones the scapula touches. So its position is almost entirely driven by the muscular support that surrounds it. And so when you see a malpositioned scapula, you got to figure out, well, why is it malpositioned? What muscles are not functioning at their normal tension? So some may be in spasm and others may be damaged, atrophy, or actually even cut in some cases, or ruptured. Or there may be a pain generator in one place that the body is compensating for, trying to pull the scapula away from it. So for me, it's seeing that it's more of an epiphenomenon. It's a sign of something else. And so I'm going to dig in deeper to what's the underlying cause.
Thank you. Fareed had mentioned Claggett a while ago, and Claggett gave a keynote speech in '62 on a big surgical convention, and he said we need to do more research on TOS, but he preferred the posterior approach. I don't know anybody who does a posterior approach nowadays. Is anybody familiar with that?
I'm familiar with it because we would approach superior sulcus tumors, lung cancer tumors from the back often, and I've also and maybe Arthur does this for dumbbell tumors, high dumbbell tumors of T1 or T2 will approach them from the back, but yeah, I've done that approach. It's no longer what I would do. I mean, I think for those indications it's reasonable, but for TOS, I wouldn't. I mean, I think you can, but I just think there are better ways to do it.
Does it disrupt the periscapular muscles too much?
It's going to disrupt. I mean, you're going to have to divide some of the trap. You're going to have to divide the rhomboids, or some of them. But I don't know that that's the reason not to do it. If you need to remove the posterior rib and decompress the proximal brachial plexus, that might work. I just think there are better ways to do it, in my opinion.
Thank you.
Yeah, I would.
Yeah, go ahead, Arthur.
Yeah, so you could say that I live in the posterior approach quite a bit for, as you said, dumbbell tumors. I've worked with a lot of my thoracic colleagues on these inside-outside chest wall, brachial plexus. I do my posterior cervical rib approach, which is a paramedian approach through a tube. So I don't split the muscles, I divide them. I spread the muscles and work in between them, and then pull the tube out and muscles fall back. But by the same token, I've also done massive periscapular approaches where you wind up dividing all these muscles, and it's like half the battle seems to be on the way in I'm meticulously tagging both sides of these muscles in multiple layers, so that when we pull them back together again, I'm connecting each part of each muscle back to where it began, because the 17 muscles, you don't want to cut 6 of them and leave your scapula completely free, or to scar in and not be functional. It's the major source of disability if you don't do it right. So I would agree that for the majority of TOS, posterior, especially open posterior, is highly morbid. But if it's really of a focal area that you want to take down, there are ways to do it minimally invasively that don't really cut the muscles. You just divide them, and then like Moses dividing the Red Sea and then letting it come back. And
maybe I can make it kind of a. Go ahead first, Rob, and I'll
Okay.
make a comment. Go ahead.
All right. Just 2 quick comments. One about the periscapular thing. It is in our peripheral nerve practice, we will see isolated suprascapular nerve, long thoracic, axillary, dorsal scapular nerve, which can affect the scapular, they call it, the dyskinesia of the scapula, right? So you can have some of those isolated, but I agree with Art that a lot of times, if it coexists with the diagnosis of the TOS, there's sometimes fairly profound effects on the scapular motion, and then two, just as that posterior approach, and we like when we do something like, so if somebody has a C5 or C6 avulsion, right, and you're going to do like a spinal accessory nerve transfer to a suprascapular nerve. I agree. That's kind of my, your posterior approach to there, where you're splitting muscle, you're trying to preserve it. So, agree, Art, that can be done. It just, I don't ever use it from a TOS approach as well, like Dean said.
I'm going to give you, maybe I can share a story that's kind of fun, and then maybe make a comment. When I told you about Dr. Urchel and everything, the reason I went to work with Dr. Urchel was Dr. Claggett. Dr. Claggett was a senior surgeon at Mayo Clinic. He had retired when I was training, but the job of the chief resident who got the Claggett Award was to spend also 6 months walking Dr. Claggett from his retirement house, which was behind Methodist Hospital, to the cafeteria at Methodist Hospital to basically get him breakfast, and then spend an hour learning from all his experience. And that was the greatest privilege of my life, honestly. So Dr. Claggett would talk about this. And the reason they did the posterior, just like Dean and everybody said, this is a very disruptive incision. This really messes up a lot of things. And they did that because they had that superior sulcus approach and all that experience, and they weren't really happy about the transaxillary thing that was coming along those days. But anyway, that's the kind of a fun story. So I think that Dr. Claggett would say this is not a good thing to do for TOS, because one of the things he used to say is they didn't know if the patient got better or not because they had so much morbidity associated with the incision. So that was a problem. The other thing I would like our questioner to think about, and maybe others, is that we think that one of the things that occurs in this venous disease with the compression of the subclavian vein, which is the only draining part for the upper extremity, including the scapula, the arm, the side of the chest, and the side of the neck, it's a similar phenomenon to crossing your legs. Everybody knows what it feels like to cross your leg when your leg falls asleep. And it'll go from paresthesias all the way to where it feels like it's not even part of you. You don't have to lift it up with you. And that pain that you get. So pain does not necessarily mean that the nerve is being compressed. If you have ruled out compressive disease, some of these patients with scapular pain, some of the patients with these very non-specific kinds of upper extremity pain actually have the same phenomenon as crossing the leg syndrome, but the upper extremity. It's fascinating, the anatomy and the blood flow everything is very similar between the thoracic outlet and the knee and what's and so forth. So that's something to think about.
Great. Thank you for the good question. It's good. We got good discussion out of that. Hannah says, I'm trying to get pregnant, but I'm suffering from TOS symptoms. Still trying to figure out what kind of TOS I have. Is it safe to get pregnant with TOS? Rob, do you have any experience advising patients on this? Anybody?
Well, I mean, I think I would say, how much pain are you in, and are you requiring any medications, and just think about what are those demands on you to treat your current symptoms. And if it's very positional, it's postural, and you've controlled it with therapy and ergonomics and those kinds of things, it's probably okay to proceed with that. But if you're living with 6 to 8 out of 10 pain, you have weakness in your upper extremity, you have dyskinesia of your shoulder, requiring medications, all those things are probably things that suggest perhaps get that treated first. Kind of my knee-jerk thoughts.
And with all the stuff we've talked about, whether it's compression, venous congestion, or whatever, the edema that comes with pregnancy may make it worse. So your point is well taken. Have this well controlled ahead of time. Other thoughts on this question? Yes.
Yeah, I would also say you want to make sure you get checked out for any possibility of pelvic congestion, because obviously as the uterus is going to get bigger and bigger, it's going to be pushing onto those pelvic veins. And so if there's any contribution from obstruction elsewhere in the venous system, it's only going to get worse during pregnancy. And in fact, actually, we know that there for a number of reasons, other parts of the body become much more congested. And so I would say that your TOS symptoms probably would get worse on average, are more likely to get worse during pregnancy than they are pre-pregnancy. So if you might want to get it worked up. Plus, also, if there's going to be any treatments you do also have pelvic venous obstruction, you wouldn't want to necessarily have the radiation exposure for having that treated while you're pregnant, if it becomes a bigger problem. So I would suggest you get a workup before getting pregnant, unless the pregnancy issue is kind of urgent. And sometimes it's the right time, and you can't choose that.
Thank you. Is McCleary syndrome a clinical diagnosis? I think McCleary syndrome is a symptomatic compression of the veins, the subclavian veins. It acts kind of like a venous TOS, but with no blood clot. There's not a lot of literature, but since McCleary wrote about it, there have been papers that came out every few years on it. Anybody have any specific thoughts on this?
I guess I would say, to me, a clinical diagnosis is something you can't confirm or prove. And I think with McCleary's, you can, either with a venogram or a, CTV or MRV. I think you can sort of show stenosis even at rest in a patient that's got clinical signs of venous insufficiency. So I think you can make the diagnosis of McCleary's. I guess it's not a pathologic diagnosis, because we're not biopsying and prove anything, but we certainly have good radiographic evidence. So,
yeah. And McCleary first wrote about it, I think, 1939. So at the time, it was maybe clinical. I also notice in your icon here, or your badge, it's a Canadian flag. So I wonder, also from the screen name, it's a patient who's, as we see occasionally, we get patients from Canada who have trouble getting really worked up for TOS. So if you want to contact us, we can help steer you to the right people and get maybe a little bit better answer with imaging, etc. Thanks for the question. Funky Manor says, if scalenectomy without first rib resection can be successful with a majority of patients, why is first rib resection generally considered the standard procedure in TOS surgery? So, Rob, I'm going to start with you, because you actually kind of brought this up, but your patient group is a little bit different. So please address this question.
So, again, it's about stratifying care in my practice, and I just try to be thoughtful about the three different components. And if there's not an obvious costocavicular component, then we hedge to doing a non-rib removal type approach. Scalenectomy. I think again, I do a subtotal anterior scalenectomy routinely for all those patients.
But there are some patients of yours that do need first rib resections.
Yeah, for sure.
And so this is part of where the different diseases all lumped together as TOS make it a little more difficult. I'll just say, it's something I've said before as well. I think there are static components like extra muscles, narrowing, scaling triangle, versus dynamic components in this very complex structure. Dean, how would you address this question? I don't think your practice is that the majority of patients can be treated without first rib resection. Is that fair?
Well, I don't know for sure. I do know there's no question scalenectomy alone will work. There's no question that a partial rib resection will work. Just taking out the anterior rib, a scalenotomy will work. How I look at it is, what's the potential downside? Because if in the percentage of patients, and it's probably not a very big percentage, but in the percentage of patients that have those operations that fail, you're kind of then doing a redo. And I've done a lot of redos, and I think I age a month for every one of them. So how I approach is I don't want to do my own redos. So I'm sure I've done more surgery than a certain patient needs, but I've done scalenectomies in the past and they've failed, and I've had to go back in on my own to do a rib resection. And I was certain that the scalenectomy was the right thing to do, and I was wrong. And so to me, it's a matter of I want to be very careful of who I pick for surgery, but I want that patient to have one operation and be able to know, there's nothing more I can do. If this doesn't work, then I know to the best of my ability that thoracic outlet is decompressed. And I personally find it very hard to select out scalenectomy patients, partial rib resection patients versus my approach, maybe a more aggressive or more, aggressive decompression. Because the people, so many patients, most of the people I see have scalene anomalies. The scalene muscles embryologically start as one common muscle mass. And as the forequarter develops, it pulls the neurovascular bundle through it. So I think almost all of us have these scalene bands that can cause symptoms, but most people don't have TOS. And when you look at autopsy studies, a very high percentage of patients have scalene anomalies, and those patients had no symptoms. So I still think it's hard to be able to cherry pick the right operation for the right patient. So I think you have to pick the right patient for an operation. Again, this is my opinion, the right patient for an operation. And then I just try to do a complete decompression, or what in my mind is a complete decompression.
Great. It's a great description. Yeah, it's true. We know a lot of people have anatomic variations. Okay, I'm going to ask one more question now. We'll see how much time we have left. My question is, I'll start with Rob this time. What do you think the future of TOS is, or more specifically, what would you like to see in the near to middle term future for TOS?
Probably again from my optic, and the topic that I've hit is just having all of us continue to share information like we do, and that we're doing tonight, which is spectacular. But again, for me, like we've done in different parts of the body, peripheral nerve, is to better stratify care, and just can we do that and still maintain good outcomes and have low rates of revision surgery. I think that's really, and just working on our diagnostic tools. And I think the diagnostic tools will help us continue to get better and better at that.
Great. Fareed.
Well, not to sound like a broken record, but really, I hope as time goes on, we can sort of clarify the waters. These waters are really muddied, and we just need to clarify them by finding all the different pathologic processes that end up with this common pathway of having upper extremity pain and all of the various things that we call TOS. And I think the more specific we get and the more we know a diagnosis before surgically attacking it, the better results we're going to have. And I hope that at some point we don't use surgery as a means of diagnosing TOS. Those are my hopes for the future.
Thank you. Art.
Well, as I said, I'm hoping for better neurodiagnostic testing, to be developed. But I actually think 20 years from now, we're going to be doing something that resuspends and resupports the scapula in a better position more than we're taking out the first rib. I think the first rib is just an innocent bystander in all of this. What did the first rib do? It was just kind of sitting there. But that it's the position of the scapula which drives the clavicle, which then puts the neurovascular bundle under tension, which winds up pulling on this, changing the angle that the brachial plexus makes with the scalene muscles. I think that somehow or other we just need to better understand that maybe we'll have electrophysiology of the 17 scapular muscles, and we'll actually be able to see, oh, it's the levator scapula that's damaged in this patient. It's actually your trapezius is in spasm here, or your pec minor is in spasm, and somehow or other one of these is, and we'll actually tailor the treatment to that, rather than taking out this poor innocent bystander that he was just hanging out the top of his hood, and suddenly some guy comes along and rips him out.
Dean, I almost feel guilty asking you to follow up on that.
Yeah, I can't top that. Although that is a fascinating idea, and I do think scapulothoracic fusion is definitely a very hot topic here. Bassem El Hassan is one of our orthopedic surgeons who does a lot of scapulothoracic fusion work. Anyway, in terms of the future, I would still think the big hurdle for me is diagnostics and trying to get it right. We've got a very large clinical database, and our fellows right now are kind of trying to take that and really parse through it and try to get a better way to make an accurate diagnosis. I think we do a pretty good job. I know we can do better. But that would be what I would want to work on is improve diagnostics so that, we can really identify who's gonna get better with non-surgical treatment, who's going to get better with surgical treatment. Because all the people that I put through, months of therapy and treatment, and then ultimately they went to surgery and they did great. If I had just operated on them, we would have saved them a lot of time and anguish. I just can't identify them ahead of time. And the hard part is there's so many people who just get better and never need surgery. So I certainly don't want to operate on everybody. I want to pick the right patient. So that's still, I think, the big hurdle that I'd like to tackle.
Thank you. I want to thank each and every one of our panelists. It's a pleasure for me to listen to the amount of brain power on this call. It's just I'm so lucky to have this opportunity to learn about something like this from people like this. For our viewers, I'm sorry if we didn't get your questions answered. It's really hard to cut down the content from all of our great speakers. But if you reach out to us at our website, tosmri.com, we're glad to hook you up with any of these people and to do our best to help you get your questions answered. And I would say, hopefully we can do something like this again. I just really enjoyed it. Again, thankful for your time. And so this is Dr. Scott Worden, the TOS guy. Thank you all for attending. Don't forget, hit the like button, subscribe to us, and right near the subscribe button, I'm supposed to tell you there's a bell. Hit that bell so that you get regular updates about when our next video comes through. We're at 600 full subscribers, and we're aiming for 1,000, which by YouTube's criteria will allow us to do more. So get your friends, family members, even your pets hooked up. Let's get those subscribers up over 1,000. All right. Again, thank you, Rob, Fareed, Art, and Dean, your first time with us. I'm so thankful. I really appreciate it, guys.
Thanks, Scott.